panelists have not arrived, we as speakers will start introducing each other. So our first speaker is Dr. Narmata Kabra, Senior Consultant, Center for Sight, Mumbai. And she will speak on the topic overview of refractive surgeries. Over to her.
Thank you so much, and good afternoon, everyone. As all of you know, the prevalence of myopia is increasing, and so also the tsunami of myopia is coming. We have to be ready for the future. So being future ready does mean we should know all of our weapons as well, isn't it? When Palikaris, he introduced first refractive procedure, that was LASIK, and here we are. With the process of evolution, we have n number of options now with us. We need to know all the pluses and minuses, strengths and weaknesses of our heroes. And that's how we can utilize all of our heroes in our battle. And the chances of winning improves when we know who is the villain and who are our heroes. First and the foremost, captain of our team, LASIK. Yes, still this procedure holds one of the best option till date and most widely performed refractive surgery till date. In this, a high oscillating blade, the microkeratome blade, creates a flap, and after lifting the flap, the excimer laser takes care of the refractive error, and the flap is placed back. And you can see the different assemblies, different parts of the assembly, and based on the different specifications, it can be pendular movement or linear movement, and these are specifications with different devices available throughout. So, what are the pluses? Early visual recovery, very minimal tissue reaction, very minimal discomfort if we compare it with PRK. No additional inflammation, no haze formation, and retreatments are really, really easy. But it comes with the weakening of biomechanical strength because of obvious reason, flap making. And microkeratome related complications are something which is unique for this, including incomplete flap, free cap, especially for flatter corneas, and buttonhole in case of steeper corneas, which has worse outcome amongst two. And we need to know, we should be aware of subtle, finer refinements required when it comes to very steep cornea and very flat cornea. And advent of femto-LASIK, it's a boon to overcome the microkeratome-related complications. It's bladeless, and it minimizes flap-related complications, especially microkeratome. The flap configuration is planar as against LASIK, the microkeratome. You can customize hinge location, flap thicknesses, and it's very soft when it comes to docking. Opaque bubble layer is one unique complication with this procedure, which vanishes if you wait for a couple of minutes. Rest of the complications like rainbow glare and transient light sensitivity with increased chances of DLK have really gone down, just because now we are with second and third generation of machine, and the amount of energy used is really less. But irrespective of that, still this is a flap-based procedure. So flap dislodgement chances are there. To overcome this, there is one more hero. So we have every reason to smile now. This is absolutely flapless, and a small incision is created after femto-assisted lenticule dissection. You dissect it out and you remove this lenticule through a very small incision. So this is truly flapless. So good for sports people, contact sports especially, and some of the special professions where there is requirement for flapless procedure. It transects less amount of nerves. That's why induced dryness is also less. Visual, I would say, not rehabilitation exactly, but one can start working and resume the normal working very quickly and early with this procedure. It retains biomechanical strength in a better way as compared to any flap-based procedure. And again, very soft docking and low suction IOP. But it comes with a burden of steep learning curve. There can be retained lenticules, lenticular part. It can create stromal scarring, especially with the beginners. eye tracking, hyperopic and astigmatic treatment was an issue to begin with, but with Near Smile Pro, you have all these options included. Now there are a couple of more platforms, especially when it comes to lenticule-based platforms. Silk is also there nowadays available. It's faster device, and the ease of dissection is better. Amount of energy being utilized is on lower side. And in market, with every new addition of lenticule platforms, now the new nomenclature is CLEX, that is keratorefractive lenticule extraction for all these procedures. So for the sake of any publication here onwards, Smile, Silk, Clear or Smart Sight, these terminologies won't be accepted. You need to know one unsaid hero, that is surface ablation. These procedures are really picking up, and the trend is towards non-flap based procedures. You can remove epithelium with the help of alcohol, with the help of mechanical HSK blade, a Moyle's brush, or with the help of PTK mode. And this is very technically easy to perform, especially when it comes to non-cornea people. They are also venturing into flapless in true sense, and good option for thinner corneas where you need to retain good mechanical strength, and good for very narrow fissures where docking can be an issue. But it comes with a baggage of very high post-op pain, longer visual recovery, and haze formation. You need to know the grading of haze, and mitomycin comes as a savior when it comes to haze. Meta-analysis study and all the studies show it prevents haze formation. It's not moving further. Sorry for the technical glitch. Phakic IOLs. Phakic IOLs is a very good option for LASIK rejects and high myopes. It maintains contrast sensitivity, and it's also a good option for thinner corneas and faster visual recovery. Of course, you do have unique complications of cataract and raised IOP. If the vault is too low or too high, you need to understand the optimum vault. And when one hero cannot take care of villain or cannot defeat villain, then second hero has to come into picture. Bioptics is something like this. I'll just wind up in a minute. If you combine two procedures together, that is ICL and surface or ICL and LASIK, you can take care of higher refractive errors. Refractive lens exchange is also one of the options to take care of these high refractive errors, especially LASIK and ICL rejects, but you have to be aware of increased chances of retinal detachments. This is just a table which speaks for the same, and there are a couple of newer options which one needs to know, or good idea to know, especially enhancement procedures for hyperopes, which is picking up very fast. And these are special situations where you should choose one hero over the other, and it would be good idea to know this. Thank you so much. So now we have so many hands, and we have a battle. Just choose wisely. Thank you. I would like to invite Dr. Colonel Bandopadhyay sir for the next talk.
Okay, good afternoon, everybody. So today my topic is about demystifying the phaco machine 4th generation. So no financial disclosure. So basically we are going to have a brief overview of the cataract machine, that phaco machines from 1st generation to 4th generation. And main crux of the presentation is we are using the 4th generation machine now. But what is the mechanics? We know how to use it. We are doing cataract surgery. But what is the hardware behind it? I'm going to explain a little bit so that you have a better idea of so many machines available in the Indian market nowadays. So again, my basic historic, the 1st generation had basic inflow and outflow and phaco power, but nothing was very controlled. 2nd generation came, improved fluidics and vacuum control, but a lot of things still lacked. 3rd generation, we had a good control over the fluidics, but still post-occlusion surges were there, and surprise PCR ran due to chamber fluctuation was there, and also power delivery was not very focused, due to which sometimes thermal burns was noticed. The 4th generation is very precise, very focused, and chamber stability is maintained. So that's what I'm going to tell about technicalities of that. So enhanced fluidic system, What is the hallmark of fourth generation? Improved ultrasound technology. It achieved in various ways by various companies. Reduced energy use while maintaining efficacy. And again, surgeon can adjust the parameters. So what matters in phacoemulsification? That is the main thing. So one is safety, to reduce the complication. Efficacy, so that we can handle the nuclear management is better, easy, and the learning curve is less steeper. And stability. We want the chamber to be stable. It is for both comfortable to us and also good for the patient. So what is these machine achieving? We normally operate at a higher IOP than physiological. That is above 17, the older machines. But now we are approaching 40, 30, and we are also publishing papers on that. So why physiological IOP is good? Maintains and improves the surgical efficiency, less corneal edema, less damage to the endothelium, and also less intraoperative pain to the patient when you are doing on topical surgery. So these are the studies which I will give the reference later on. That is the corneal endothelial cell density is better after low IOP surgery, that is physiological IOP, and result in less corneal edema post-surgery. So coming to the one of the most, like in our center, we have all the fourth generation machines. That is the Centurion Active, Stellaris, and Bosch and Lomb. That is the this machine. So coming to the Alcon machine, the Universal 2 was the first. We have operated on that. A lot of complications. They have improved on that. Coming to the Infinity system, third generation, and the Centurion Active Sentry, the fourth generation. Wonderful machine. So now start with the Alcon. So fast responsiveness is the key. Surge reduction is is not there. It's so fine refined that chamber is stable throughout the surgery. And phaco tip is very ergonomic and it is very safe in the current fourth generation machine. So these are the things again. So coming to the basic, what is the feedback, how the chamber is maintained. So you see the number one is the fluidic pressure sensor directly in the handpiece, which monitors what is the intraocular pressure during the surgery. Then it gets feedback to two other systems. That is two is the processor, which is inside the machine, which gives command to the active fluidic technology. Normally the infusion is gravity driven in the older machines, but here it is a compression plate. Depending on the feedback from the sensor, that is one, and the microprocessor 2, the pressure on the bag is modulated so that the infusion into the eye is maintained and the IOP is maintained. And the 4 is the quick valve technology, which is a venting valve, and it got a roller, 7 half rollers, a peristaltic machine, but again more control on the vacuum created. So the surge control is very good in this machine, and the IOP is maintained in a wonderful way during surgery, which I will also show the video. So this is what happens. The yellow line is a gravity-driven infusion, while that blue line is what is the active fluidic technology. You see there's a lot of difference after surge. So again, the tip power is compared, so they are more efficient nowadays. The Alcon has come up with two tips, basically the hybrid tip, which is designed in such a way that there is less thermal damage to the incision and very focused power delivery. And they have got a hybrid, that is the tip, where it's got a polymer in front. So for grade 1 and 2 nucleus management, even if it touches the posterior capsule, the chance of rent is very less. So this is a protected tip. So here what is happening, the balanced tip and the protected tip, the chance of PCR is very much less. So this is again the harmonic handpiece. So this is the video. So you focus on the IOP. See, we are doing a lot of procedures, trenching, then doing the nuclear management. IOP is stable, maintained at 40. So that's the good thing about this machine. So all the parameters changing, vacuum, but according to the Bosch and Lomb, Minilium 4th generation, Stellaris, then the Stellaris Elite 4th generation. Again, they have developed on two sides, that the power delivery. So here the adaptive fluids, got an active reflux which controls the reflux and the surge, and got a yaw movement on the foot pedal, up, down, and the yaw movement. So what this is happening, that is the adaptive fluid. What they have done is the bottle, they have got a pressure infusion. Instead of the plates which are used by the Alcon machine, they have got a pressure infusion into the infusion bottle. So depending on the surgeon's foot pedal movement and the vacuum feedback, the infusion is maintained by a active pressure method. So that is what happens in Stellaris machine, that 4th generation. So this is the whole setup. Doctor decompresses the foot control, system receives command vacuum, system adjusts the infusion pressure, and adaptive infusion pressure flows from bottle to the handpiece. So the chamber is very stable. So these are the part of it. So the potential benefit is again surgery at the physiological IOP. good for glaucoma patients and high myopia. So this is that again gravity driven in their own diagram, showing that it is better surge control from a gravity driven infusion. They have made a attune energy tip, which is beautiful in that it got 6 crystals. Tradition is 4 crystals, so that the heart frequency is reduced, heat is also generation is reduced, and the stroke length is increased. More cavitation energy and more jackhammer effect. So that's how they made it. So these are the unique foot pebble. You also you got another movement. Coming to Johnson & Johnson phaco machine, they started with Sovereign Station to White Star. That is the Veritas vision system which we have got. So the crux of that, again, they have got an elliptical tip movement. Hybrid fluid technology. They have got both peristaltic and a Venturi pump. So you can modulate your surgery according to that. They have got an intelligent oxygen sensor in the cartridge which senses occlusion and accordingly does the IOP management. So dual pump system, like peristaltic is good for the nucleus control, and the Venturi mode is good for the fragment removal and IOP control. So this is the technology, like I told you, tip is again has got a elliptical, and they've got a hyper phase technology. So this is what happens in the Veritas machine. They have got a unique handpiece with a dual. So this what is a White Star technology, that is hyper pulse technology, which on and off power with good cooling time, dual pump system, advanced tubing, less compliant but a flexible tubing. And so this all affects the surgery. Again, this. So here it is compared. So every machine and the company has come up with a unique way, but ultimate is good surge control, IOP maintenance, and focused power delivery. So that is the crux of the 4th generation phaco machine. So these are the references. Thank you.
Thank you so much, sir, for such a brief, wonderful review about all the high-end machines which are available, their pluses and minuses. Next, I invite Dr. Jayalakshmi Govindan for delivering a talk on cataract and myopia. She'll be enlightening us with a talk. There is a little bit change in order on her request. Thank you.
Good afternoon, everybody. Thank you, AIOS, for giving me this opportunity. So today my talk is on cataract and myopia. Especially I'll be dealing with high myopia. By definition, it is spherical equivalent less than -6 diopters and axial length more than 26 mm. We are more concerned about it, as we know, as the first speaker said, the tsunami of myopia is growing globally, especially in East Asian population, and it adds to the economic burden as well. So many studies have found this association, and especially the nuclear cataract and posterior subcapsular cataract are the dominant types of cataract in myopia. So what is so unique, and why are we talking about this kind of cataract and myopia? Firstly, it is presents early, and these younger population comes with greater expectations, with a lot of demands. There's also a lot of risk involved, both intraoperatively and postoperatively. And if they had already undergone refractive surgery, then post-op prediction error is a big headache. And because of increased higher order aberration, they see cataract surgery earlier. And the biggest challenge is accurate biometric calculations, including choosing the best IOL formula. So other than nuclear cataract, we have to remember the other 3 major risk factors associated with high myopia are maculopathy, retinal detachment, and primary open-angle glaucoma. A quick review about how cataract happens. It's mainly because of vitreous liquefaction, whereby there is increased intraocular oxygen tension combined with antioxidant capacity reduced amount. This imbalance leading on to denaturation of proteins leading to nuclear cataract, and retinal degeneration byproduct mainly because of lipid peroxidation causing posterior subcapsular cataract, and at the same time some kind of microinflammation also happens which adds to the cataract formation. So preoperative evaluation, we should start with the nature of complaints, especially note for any sudden decrease in vision where we should think about any maculopathy involved, any previous history of refractive surgery or retinal procedures done. Detailed fundus examination is a mandatory, and if we have ultra-wide field camera, it will be very helpful. Investigation must include OCT macula, PAM to prognosticate, and of course biometry. But the biggest and the greatest challenge is giving a proper counseling to know their expectations as well as to explain the risk and complications involved. So, but however we do, the refractive outcome is always less predictable because of error in the axial length measurement because of posterior staphyloma. we can overcome to an extent by doing optical biometry, or you can use newer generation formula, mainly the Barrett's Universal 2. So Barrett's Universal 2 can be the best formula both for axial length lesser and greater than 26 mm, have a target refraction from minus 0.5 diopters to minus 1.575 diopters. Better to choose monofocal IOLs as multifocal IOLs because of the capsular bag and IOL disparity. There may be chances of decentration and decreased contrast sensitivity. And for spectacle independence, go for monovision or crossed monovision. If you have intraoperative biometry, it will be very helpful. But if they have already undergone post-refractive surgery, then we have to have a detailed evaluation of prior ablation, the higher order abrasion profile, and note for any corneal irregularity, and see that if they are a candidate for post-surgery corneal laser enhancement, use a proper IOL calculation, and see for any decentered ablation or irregular in depth of the laser surgeries. Yes, challenge is again in biometry calculation. There are so many solutions offered, and the best IOL formula will be to go for Barrett's Truque no history, or to use ASCRS IOL calculator. So, and again, IOL selection can be monofocal IOL, or if we have any kind of refractive surprise, if we expect any kind of surprise, then go for light adjustables or small aperture IOLs. So intraoperatively, again, we start with topical anesthesia. As the previous speaker said, to have antechamber fluctuation should be avoided in any cost by minimizing incision leakage, and have the lower bottle height and increased flow rate. And watertight wound closure must be the endpoint. And if you are choosing SICS, be ensure to even put a suture at the end. And the well-centered moderate size rexes should be aimed for. And lens iris retropulsion syndrome is one of the characteristic of in these cataracts, where it is characterized by AC deepening, pupil dilatation, concave iris configuration, leading on to reverse pupillary block. It can be avoided by lifting the inferior iris with the Sinskey hook. So don't hesitate to use the capsular tension ring if this is doubtful zonular dehiscence or zonular weakness. And IOL must be completely covered by rexus margin, and better not to leave them aphakic, and at least to put a 0 per IOL to avoid vitreous movement. And in case of any surgical changes has to be done if post-refractive eyes, like RK, avoid the RK incision or go for scleral tunnel, and better do put a stabilizing suture. In post-phakic IOL, the risk of endothelial injury should always be in mind, so use a surplus amount of OVD. So coming to refractive outcomes, there is significant visual improvement in these eyes, but which is mainly due to removing the dense nuclear cataract and removing the greater prismatic effect of spectacles. But the percentage as per the Zio et al. In meta-analysis is only 63%. And the percentage decreases as axial length increases. And this poor visual outcome is mainly attributed to pre-existing myopic maculopathy, newly onset post-op complications, or post-op hyperopic drift. And this same kind of outcome is being studied in Shanghai myopia study, where they attributed the poor visual outcome, apart from those listed above, to corneal astigmatism or decrease in subfoveal choroidal thickness, or because of again the same the PCR rate or the post-op complications. Post-op complications, first and foremost we worry about is the PCR rate. As per the study, it increases with every 1 mm increase in axial length because of zonular weakness and vitreous liquefaction. But there can be negative correlation as well, because it's mainly handled by experienced surgeons, and high myopia patients, they present early, and with advanced equipment, PCR can be avoided. The retinal detachment should be always in mind, so better to avoid any kind of complications because of movement of lens capsule or decreased stability of the vitreous body can lead to RD in any time in life. So maculopathy changes as in any other cataract because of early development of PVD or PCO because of large capsular bag and thinner IOL, but may not be directly attributed to myopia. Yes, capsular contraction syndrome is one of a significant complication because of the increased imbalance between the fibrotic changes in the capsule and the zonules. Yes, late dislocation of IOL will be a complication which you should remember. So IOP spike is another significant complication, maybe because of pre-existing POAG or because of the anatomical change, or there can be a steroid responder as well. So refractive surprise is only major thing which we are most worried about. That's why we keep stressing on counseling to make the patient happy, or go for either laser enhancement and rarely piggyback IOL and IOL exchange, mainly for hyperopic LASIK patients. So 5 P's we should remember: complete pre-op examination, evaluate biometry data and formulas, pre-operative counseling the patient very well, and be prepared for any intraoperative surprises, and plan for anisometropia between the eyes. So if we remember all these and go methodically and do the surgery meticulously, we can give a spectacle independence for any kind of high myopia, be it celebrity or any common man. So myopia is just not a refractive error. We should think beyond it, and it's very complicated. Thank you.
Thank you, Dr. Jayalakshmi, for sharing your pearls.
May I ask
on
a question?
Yeah.
Madam, very nice presentation. You showed some relation between the high myopia and the cataract. That slide. Can you come back to that slide?
The studies?
Yeah.
No, the busy slide which shows a lot of
Shanghai study?
No,
Tree
the
diagrams.
relation between the high myopia that leads to
vitreous
subcutaneous cataract
liquefaction
later on.
and,
Yeah, the
leading
cataractogenesis.
to-
Open. This one? So because of axial length elongation, vitreous liquefaction happens, right? So there is increased intraocular oxygen tension. There is more of reactive oxygen species is produced. So, but the antioxidant level is not able to compact this kind of increased reactive oxygen species. So because of this imbalance, there's denaturation of proteins, which is one cause for nuclear cataract, as well as there is hypermethylation of genes which encodes the alpha crystallins. So that all leads to nuclear cataract. Another proposed mechanism for posterior subcapsular cataract is the retinal degeneration byproducts. So that is because of lipid peroxidation that leads to PSCs. So plus all other microinflammations, and it is all proposed theories.
Thank you. Thank you so much. In view of time, we would move to next talk. I would like to invite Dr. Shalini Mohan for enlightening us with the talk on combined surgery. So after myopia, probably the expected surgery is combined surgery for some of them, if not for all. This is again a change in the sequence on request. Thank you.
Thank you so much, Dr. Namrata. Good afternoon to everyone. So I will be talking about the combined surgery, that is combined cataract and glaucoma surgery. I don't have any financial interest. It's not moving. So what are the indications of combined surgery in our scenario? Whenever we have patients of cataract with uncontrolled glaucoma, or patients having progression despite controlled intraocular pressure and having cataract, and then cataract in the patients who are non-compliant due to any of the reasons. So whenever we are doing a combined surgery, there are potential advantages of the surgery, like it is convenience because it is a single setting and we are doing both the surgeries simultaneously. We avoid post-operative IOP spikes because we are doing trabeculectomy. There is long-term IOP control and patient has reduced medication usage or can stop medication usage. But then there are potential disadvantages like more of intra and post-operative complications. Cataract surgery in patients with glaucoma might be more challenging, and if there is a vitreous loss, the trabeculectomy surgery might fail, and there is somewhat more of inflammation because there are two surgeries simultaneously being done. And then sometimes combined surgeries are less effective than only trabeculectomy surgeries. So what are the special considerations we should look at? Poor pupillary dilatation, so our basket should be ready. Inadequate anterior chamber visualization and anesthesia, whatever you are comfortable with, no harm in blocking these patients. So this is a same site surgery. Now this is injection of subconjunctival mitomycin C, which now we do regularly. So here we are sitting superiorly and completing our surgery from the same side, both trabeculectomy and phacoemulsification. After you making your capsulorhexis, as you all do, we dissect the conjunctiva for making the flap. So here you are seeing the dissection of conjunctiva. A gentle cautery is required, and then you mark incision 4 mm behind the limbus, and then dissect the tunnel, partial thickness scleral flap, as you do for your small incision surgeries. You enter the AC by 2.8 keratome, and you complete the phacoemulsification by the similar tunnel. So you can see the tunnels, the scleral tunnel through which phacoemulsification is being completed. After completion of phacoemulsification, thorough cortical cleanup is mandatory in these patients because of increased risk of inflammation, and then of course IOL implantation. Now, after IOL implantation, we would proceed with the trabeculectomy surgery. So through the same partial thickness scleral flap. So here putting of IOL, and then after that we need to inject pilocarpine so that the pupil constricts so that you can do a nice iridotomy. So this was injection of pilocarpine, and then now coming to trabeculectomy surgery. So the same flap which you have made previously, there you need to cut sideways with your Vanna scissors. So here cutting of flap so that now you have nice partial thickness scleral flap. You need to identify the junction of grey and white, anterior to which you have entered, and this is the cos sclerostomy punch which is used to punch. So it comes in two sizes of 0.5 and 0.75. So you can cut a nice ostium with the help of it. If you feel the size is not okay, then you can enlarge the opening also. And here you see that there is nice ostium which is there, through which you need to do your iridectomy so that iris doesn't come and block the ostium. Now this is followed by suturing. You can put non-releasable sutures if laser suturolysis is freely available with your center. Otherwise, putting one releasable and one non-releasable is always a good idea. Now, after burying the knots, you have to close the conjunctiva, which should be extremely watertight closure, which is very, very important to get good post-operative bleb. So these are two wing-shaped sutures at the limbus. Now you can see the conjunctiva is loose at the limbus, and therefore I am putting one corneal stay suture so that the conjunctiva is nicely adherent to the limbus, so that there is no aqueous leakage in post-operative period. And then you check from your side port that the bleb is forming nicely. Now here after suturing you can see overriding of conjunctiva. So whenever you have this kind of overriding, you need to cut or trim the conjunctiva so that there is no overhanging bleb in the post-operative period, and followed by injection of saline so that the bleb is nicely formed. So here you can see the bleb is formed, and that completes the surgery. So this is the combined surgery from two different sides. That means surgeon is sitting temporally for phacoemulsification, and then after completion of phacoemulsification, he changes his position and sits superiorly to complete the trabeculectomy surgery. So now in this procedure, important is that you have to choose either supranasal or supratemporal quadrant, so that in case in future the surgery fails, then you can do your surgery. So here I have put a corneal stay suture because the superior exposure was not good. We avoid putting superior rectus stay suture because it damages the conjunctiva. Here the patient was bleeding, and that happens many a time if patient has used lots of medications in perioperative period, or there is hypertension in the patient. So here you need to complete your surgery a bit quickly. Rest of the procedures are same. So this was a nice study where it compared one side versus two side phacotrabeculectomy, and it found that it yielded similar results with regards to BCVA and IOP, although in long term two-side surgery is better, so better to go for two-side surgery. So this is a small video to show how to put the releasable suture with Cohen's and Osher's technique. So you have to put a partial thickness suture in the cornea, followed by one suture at the partial thickness scleral flap. Here you can see the suture being put forever from the scleral flap to the scleral bed, and then keeping out this loop out where we need to tie. Now you take 4 throws over your forceps. 4 throws are important to secure the knot nicely, and then take the loop and tighten it. So in post-operative period, this can be comfortably released on the slit lamp. Sometimes you might be having non-dilating pupil where you might require iris hooks or Malyugin ring. Whatever pupil stretching devices are you comfortable with, you can use in your patients. So here staining of capsule is important. If iris is coming out, better to put one suture, And in small incision cataract surgery also, you can combine your surgery with trabeculectomy surgery. Post-operative medications are important. You have to give long-term steroids along with cycloplegics. So to conclude, I would say that proper planning, good intraoperative strategies, and adequate post-operative management leads to successful surgery. Phaco versus SICS is surgeon's own preference. In combined surgery, two-side surgery is preferable. Thank you so much for your kind attention.
Thank you, Dr. Shalini, for that wonderful video-based presentation. I would like to invite Dr. Sandhya for enlightening us on diabetic macular edema with cataract. Dr. Sandhya couldn't make it for some reason, and the other doctor, Dr. Shreya, is going to address. And after this, I would like to invite Dr. Ravindra to address customization of phaco parameters for the last talk of this session. Thank you.
Good afternoon, everyone. I am presenting on topic diabetic retinopathy in relation to cataract surgery on behalf of Dr. Sandhya Makhija. Diabetic mellitus is on rise across the world. 150 million people. 20% of the world diabetic are Indian. 12% of people living in Indian metros suffer from diabetes. 40% more are in pre-diabetic stage, striking the young. More common in diabetes, 2 to 4 times higher risk. One of the major cause of visual loss. Cataract surgery has been accused for causing rapid progression in severity of diabetic retinopathy. Macular edema, common cause for poor post-operative visual gain. More than 90% of patients with diabetic mellitus without retinopathy attained a final visual acuity of 20/40 or better. Patients with NPDR but no edema also have outcomes similar to non-diabetics. Patients with macular edema with or without proliferation have worse outcome. Now the difference between CSME and CME. In CME, increased permeability due to inflammation. Diabetic pathology causes increased permeability in CSME as well. The course of CME tends to improve with time, but in CSME it tends to progress. Spontaneous resolution is unlikely. Clinical presentation of CME is mild NPDR changes, absence of hard exudate, absence or minute dot linear hemorrhages at macula, while in CSME diffuse focal area of edema associated with hard exudate or more moderate NPDR. The management of CME is observation, NSAIDs, and corticosteroid, while in CSME it is immediate laser post-coagulation. Photocoagulation. As per Polak et al., British Journal of Ophthalmology in 1992, there is increased incidence of angiographic as well as clinical CME in diabetic mellitus. Development of CME is also influenced by presence of pre-existing retinopathy, development of retinopathy in post-operative period. Eye that had no pre-existing retinopathy has higher incidence of angiographic CME, while eye that has pre-existing retinopathy has higher incidence of clinical CME. The risk factors associated with poor visual outcomes are duration and severity of pre-existing retinopathy, poor visual acuity before surgery, need for PPV with or without tamponade, type of cataract surgery does not appear to influence outcome. Other risk factors are like age, gender, ethnicity, and BMI. Rules for preoperative workup are good metabolic control. Complete anterior and posterior workup is required with type of cataract and other eye status. Both eye should be dilated for examination. Assessment of type of retinopathy should be done and other eye disease should be excluded. If need and enough visualization is present, then FFA and OCT can be done for the documentation. USG scan is preferred in case when visualization is not there. These are the fundus photo with their correlated FFAs. Role of laser photocoagulation before cataract surgery reported to stabilize retinopathy, but not prevent its progression. Where cataract density prevent application, laser photocoagulation as soon as cataract wound is stabilized. Laser indirect ophthalmoscope can be considered as early. may also at time increase CME risk. Fluorescence angiogram after bilateral cataract surgery in right eye, focal laser photocoagulation was done preoperatively, shows stable maculopathy postoperatively too. While in left eye, it shows progressive maculopathy requiring laser photocoagulation. Here the right eye is phakic with NPDR, while in left eye pseudophakic with NPDR with CME and early CSME. Treating DME along with cataract surgery, we required intravitreal anti-VEGF injection after cataract surgery. Studies proving intravitreal anti-VEGF at the time of cataract surgery improves visual outcome for longer post-operative period. Combined cataract surgery with intravitreal dexamethasone implant. Combine PPV with cataract surgery if TRD, VH or VMT is there. Good patient counseling is required, diabetic status well controlled, good surgery, complete removal of cortical matter, avoid rupturing posterior capsule, lens iris touch, vitreous adhesion to wound because of postoperative CME more common, emphasize on minimum corneal end damage, corneal epithelium also slow to heal. Phacoemulsification with IOL in bag is safe. Avoid ACIOL or SFIOL. Large optic IOL can be used. Is a special care against endophthalmitis is required. Good postoperative care is required. Now the summary is patient with diabetic mellitus have high risk of developing cataract. Many already have diabetic retinopathy at the time of cataract surgery. 90% patient who have no pre-existing diabetic retinopathy carry good visual prognosis. 1/3 of patients with pre-existing diabetic retinopathy shows progression. Postoperative angiographic macular edema is common but resolves spontaneously in case of no or minimum diabetic retinopathy. While patients with moderate NPDR, CSME tend to persist and may worsen after cataract surgery. Now, the important is the good post-operative care and close observation after at least 6 months. The role of physician is also to refer the patient back to the ophthalmologist for periodic evaluation of the eye. To conclude, careful coordination between the cataract surgeon, retina specialist and physician is necessary to avoid delay and increase complications. Thank you.